Good morning. Welcome to the meeting of the Maryland Oral Health Task Force. We have our staff in attendance as well as our task force members, and we will be entertaining an agenda where we have some announcements to begin with, as well as group report outs of those groups, subgroups that have material to share, and then proceed with presentations from 3 guest speakers that will help to inform the subgroup work as well as the larger task force interim recommendations, which are pending. But before we do that, let's have a roll call to make sure that we have an appropriate quorum, and we'll proceed from there.
All right. I don't think Dean Reynolds has joined us yet. Emily Dow.
Here, present.
Hakan Koyman? Don't think so. Debony Hughes. Good morning. Charles Doreen. I've seen.
Yes, present.
Ricardo Kimbers. So Jennifer Szyminski. Anna Davis.
Here, thank you.
Christy Russell.
Present, thank you.
MJ Kraska.
Here.
Jean Carlson.
Present.
Good morning.
Morning.
Marpana Verma. I don't think is here yet. Jennifer Bremen.
Good morning. How are you?
Good morning. Mary Backley.
Good morning, present.
Carol Masden is no longer with the task force. Diane Romaine.
Present.
Brooks Woodward.
Present. Good morning.
Nicole Steck-Waite. So Dean Shiflett.
Present.
And Sarah says we heard was not going to make it. And I see Dr. Verma is just getting into the waiting room. So I'll go ahead and mark her as present as well. And that's it.
Great. With the quorum present, we'll we'll start our meeting. I would like to start with a request for a vote from the task force about a January meeting. We are about to enter into session. There is a lot of activity there too, and Delegate Bagnall, if you want to weigh in, you're welcome to, including potential movement on dental and oral health care. We won't preview that here per se in our task force, but it'll be a very busy session. So in advance of the task force going into a bit of a hiatus as we work on crafting our interim recommendations and provide a progress report, I wanted to suggest a meeting on January the 6th that will proceed, or right in the middle, or beginning rather, I should say, of session before things get too overwhelming. And I wanted to check with the task force members about their availability and their desire to meet in the beginning of January. So I'll open that up for comments, feedback before I ask for a vote on that. Dr. Verma.
Thank you. January 6th actually falls in the middle of a conference that the board attends each and every year. And so neither myself nor my surrogate would be able to attend that meeting.
Okay, thank you. Noted. Other folks? Dr. Romaine.
I would just ask that it could be a meeting later in the day so we didn't have to cut down on clinical hours. After the holidays, there's a lot of busyness, so later in the day would be better. Thank you.
Thank you. Dr. Hughes, Dr. Kim, your mic, please. Thank you. Dr. Hughes.
Would that be the only meeting in January?
I believe it would be. Although if we don't have enough of folks to agree to that time, we'll try to find something in that window and would send an email out to everyone. But I think it behooves us to have a meeting in January, since at this point, we'll probably start putting pen to paper, as it were, with regard to some interim recommendations for consideration by the task force. But I would like to have a January meeting, and obviously earlier rather than later, to accommodate session and everyone else's competing interests, including, of course, all your clinical requirements. Dr. Doran.
Thank you. I would just echo Dr. Romaine. I'm looking at my clinical schedule that day. If possible, if we could do that 4 to 6, that means I only have to move around one patient. If I do it 10 to 12, it's tough.
Sure.
I'd say it's not doable, but we appreciate your consideration.
So let's do this while we try to figure out a time. I'd like to say all in favor of a January meeting sometime in the first 2 weeks in the late afternoon, and we'll send around some times that we can. I think it's probably permissible for us to get email feedback on the specifics, but let's just take the vote to say that we want to have it, since this way we can kind of mix around a little bit with the schedule and make sure that we can get as many people as possible. But all in favor of having a January meeting of the task force, say aye or raise their hands.
Aye.
Aye.
All those opposed? Okay, so hello, Dr. Woodward. Oh, just aye.
Just raising my hand in favor of the meeting.
Outstanding. Great. Thank you. And I see that Dean Reynolds has joined us. So we will send around a number of different windows to meet. I do thank you for taking the time. I know we've been pretty aggressive about our meeting schedule, but there's work to be done, and we are at this point going into 5-6 months into our mandate. With that, before we start out with the groups, I wanted to open it up for Dean Reynolds or Delegate Begnall to weigh in or provide any comments.
Delegate, I'll yield to you.
Thank you so much, Dr. Reynolds, Dean Reynolds. I just want to thank everyone once again. I was really encouraged by the breadth of the work that was presented at the last meeting, and I know that we made another commitment to get those subcommittees on the calendar. So thank you all again for carving out this time, because I think the work is invaluable.
Thank you, Delegate. So with that, we'll turn over to our subgroups. I know our pediatric subgroup, for example, due to personal circumstances for a couple of our task force members are unable to report out, but I will open it for those subgroups that do have additional information they'd like to share or present, or bring back just feedback or thoughts to speak now to the broader group before we go on to our presenters for the day. So I won't go in any particular order, and I'll open it up to the broader. Dr. Doring.
Thank you. I will share screen. I have a short PowerPoint.
Great, thank you.
There you go. Can everyone see that? I want to thank Dr. Romaine. She's been a valuable friend and mentor on this topic. And I kind of changed, you'll see the title, I changed from elder to senior, because I think some people were targeting the 65 and older group. And there's certainly people that are very active, well into their 80s and 90s. So I think to be encompassing, we look at everyone in the older age group. So this is our second presentation. And I wanted to throw in, just to kind of educate everyone, that we've certainly have had some issues with COVID-19, especially dentally. In 2019, early on, gentlemen presented with those that are, I don't mean for everyone to be a radiologist, but there's certainly some clinical caries here. For whatever reason, the patient stayed away and presented a couple weeks ago. And this is the same tooth on the lower right, if I can put my cursor there, if you can see that. And just on that lower right premolar, that decay has expanded to the extent. And certainly patients have put off treatment coming in during this time period. And not only have they put off treatment, but they've increased discomfort. They've made the treatment much more complicated. If he came in, fractured this tooth, and so it's going to be much more extensive treatment needed to save this tooth, to the extent versus a filling back in 2019, the cost is 8 to 10 times more to try to save. And then as treatment gets more complicated, certainly a loss of being out of work and traveling to the office, those are all factors that need to be considered. So much of this has affected our seniors as well. I just wanted to tell everyone that life expectancy from the CDC for overall is 77.8 years, and that's certainly in our target group. Higher for females. This is the past 2 years, and I expect this year too, this life expectancy has decreased due to COVID-19 and the opioid epidemic, which has reared its ugly head during COVID-19. The latter data here, I took some data that was published in 2004 in the American Journal of Public Health, looking at the target age group of 65 to 74. And in 1988, 45.6% of the population was edentulous, meaning they had no teeth. And then that has dropped. And then you look at CDC data from 2016, about 2% of that target population and that age group has dentures. So as our older seniors are retaining teeth, that means more opportunity for decay, periodontal disease, and more extensive treatment. Now, I wanted to talk about health inequities because this is a very big issue where someone wants to be admitted here. Okay, we're looking at percentages of individuals with no teeth. So that's edentulous, absolutely no teeth. Whether they wear dentures or not, they do not have any natural teeth. So that's 17%, according to CDC in 2016 data, 17% of US adults 65 and above have no teeth. If you graduate from high school, that drops to 9%. If you're currently a smoker, that really increases your risk of having no teeth to 43%, which I find is a tremendous risk. And then 34% among the poor, and that's in this particular study looking at 100% or less of the federally qualified poverty level. Whites at 15%, Black, it jumps back up to 31%, and Mexican Americans at 17%. So we definitely see, as far as oral health, health inequities. So I looked for specific data in Maryland, and due to a variety of reasons, I've reached out to like long-term care facilities. There's two groups in Maryland, those that are for not-for-profit and those that are for-profit long-term care facilities, and have trouble finding data in Maryland. If anyone has that, you can send it to me, it's helpful. But I did find a very good study, 2017 from Delaware. And what they did a survey of 116 facilities, all the facilities in the state of Delaware that have administrators. Now they're little mom and pop where they take care of older family members, but don't necessarily have administrators. So those were eliminated from the study. And in the study, 63% of the administrators reported having an oral assessment tool guide, but only 23% reported using it. The annual dental visit requirement for the residents in the long-term care facilities was only in 36% of the facilities. Of those facilities surveyed, 15% had an in-house dental professional that actually comes in and sees the patients, takes care of emergencies, routine exams, things like that. And 39% had a contract with a dentist, say in their local community, or they had a mobile dental clinic van that maybe showed up to the front of the facility and provided care that way. Most dental visits were arranged by long-term care facility staff and or family out that were able to put them in their car and physically take them to a dental office. So I thought that was interesting data, and I would imagine Maryland is very similar, although I would think the rate of visits due to COVID-19, the facility I was in had another COVID-19 outbreak, and they're in partial lockdown again. And this makes providing dental care, getting the dental team into these facilities a challenge. So we look at a study from November 2013, a very interesting study on dental care for frail and older adults. And in this study, published in the Journal of American Dental Association, it was a retrospective study. So they looked at, it was 2 facilities in North Carolina, and they looked at 179, if you will, 200 long-term care residents during their last year in life. So they broke these 200, a little under 200 residents down into 3 groups. Those that received no care during their last year of life, those that received limited care, maybe it was palliative care, cleaning, exam, maybe they had a loose tooth and risk of aspiration, maybe that was extracted, but care was really limited. And then a pretty significant portion received usual care. Maybe the family came and got them and took them to their routine dentist. And the median age in that study was 84.4. So the conclusion in the study was most received insufficient care, most of the residents, and comprehensive care was provided to some frail adults during their last year of life. So the study went on to state barriers to care, which Dr. Romain went over last week, but this just reemphasizes. Some of it is less of priority. If our loved ones are in a long-term care facility, they have multiple health issues, they're on multiple medications, and dental care, unfortunately, is low on the totem pole. Dental cares may not be identified, as you saw in the Delaware study. No one's even looking. So we need to improve that. Limited involvement of dental professionals. I'll talk about that in a moment. Certainly there are mental, psychological issues that affect, and we have programs such as Mouth Care Without a Battle to teach the dental team and nursing aides and things like that how to provide care for those that may be not so willing. Transportation difficulties, that's why it's important to have someone on staff. And lastly, patient resources, which we know financially is a big issue. So steps to overcoming barriers. I love this picture on the lower left. And I thank Dean Reynolds for the opportunity for me to work with the students. Obviously, this is pre-COVID-19, but here we have Laurie, a dental hygienist, Jesse, our dental assistant, and 2 dental students, 1 senior, 1 junior. And we would go on rotations at long-term care facilities. And some of my students on these externships have gone on to do wonderful things in the community, seeing patients at nursing homes, for example. Unfortunately, the past 2 years, because of COVID-19, I cannot get the students in there and all externships have been canceled. But I'm really hoping maybe in the spring we can get beyond this pandemic and do that. So I think the education is a very important part. Oral exams should be done upon admission and every 6 months for identification of disease. And also we need to train our providers to provide dental care in non-traditional settings, such as nursing homes. So to overcome all these barriers is really going to take a team effort. We need to increase the use of telehealth. Again, prior to COVID-19, the dental team was going in, sending me images, x-rays, and I'd review them at my desk. I even had trained long-term care facility staff, charge nurses to send me images when a patient had a problem. unfortunately, just like many things, they have a high staff turnover, and all these people need to be retrained. We need to educate and involve the caregivers, whether the care is provided for the homebound or in long-term care facilities. We need to educate those to help those provide the care. And then I listed COMARE here, a legislation that passed a couple of years ago to allow dental hygienists to provide care in long-term care facilities under the general supervision of a dentist. And so I think that those are all important things. Overcoming the financial barriers is going to be harder, such as adding dental benefits to Medicare for those that are most vulnerable, increasing the usage of incurred medical expenses, IMEs. This is a way for, say, a senior who's lost hearing aids or needs eyeglasses to get coverage under Medicaid. And then when I talk to people in long-term care facilities, such as caseworkers, social workers, I kind of get that deer in the headlights look, that it's just too insurmountable to do these things. And I want to provide people dentures, and I just don't know where. So I'm reaching out to those in the long-term care facilities, and maybe people in the state might know why people are reluctant to use IMEs, because certainly on the dental standpoint, my staff is ready to do this. Dental benefits to Medicare currently being considered by Congress to build back better bill. And there's a lot of misinformation on the internet about the ADA policy on this. Just to make it clear, the ADA House of Delegates, this is 300 plus dentists across the country, we voted to support Medicare dental benefits with the following stipulations: that they'd be targeted to those most vulnerable, under 300% of fairly poverty level. And in the state of Maryland, I've seen studies where that's like 48% of our seniors. So it's a substantial benefit. It's a substantial cost as well. Covers a range of services necessary to maintain and achieve oral health. Is primarily funded by the federal government and not fully dependent upon state budgets. So our state people will be proud of that one. And then provider enrollment and reimbursement, satisfactory to support robust provider network. We've learned through Medicaid some of the challenges for providers, and so we don't want the same thing to happen under Medicare. And allow freedom of choice for patients. If they've got a relationship with a dentist, they should be able to continue that relationship and still get the full benefit of the program. And then just this last month, Senator Ben Cardin co-introduced a bill that does provide Medicaid Dental Benefit Act for adults. And although it doesn't target the 65 and above, anything we can do to prepare people, our seniors, dentally as they enter into the golden years would be a big, big plus. So we would support that. And I'm talking to Mary Backley this week, the Maryland Dental Action Coalition actually has a bill that does the same kind of thing for Maryland. So we're very, very excited. And Maryland State Dental Association would certainly be interested in that. So at this time, I'll take any questions, and thank you for the time.
Thank you, Dr. Ron. You don't have any questions, or I'll throw up my hand. Question on the smokers. We all know smoking is bad, but the 43% related to that have the oral health issues, is there a clinical nexus directly to smoking to oral care? And again, I'm not the clinician, so I posit that question.
Well, we know those that are smokers, and if you throw in alcohol, there's a very high risk, or it increases your risk, I should say, of oral cancer. As we certainly know, periodontal disease in smokers is more advanced, so that would increase tooth loss. The interesting thing about smokers, and Dean Reynolds maybe could comment on this, when you look at a smoker, certainly they may have some stain on their teeth, but they don't have the same inflammatory process that non-smokers. So their gingiva, their gum tissue may look pink and healthy, but underneath, somehow it's dampening the immune system, and the bacteria that's present just causes more severe bone loss. So they may at first glance look like they're okay, but they're really at higher risk for gum disease.
And Dr. Hughes and other folks, have we targeted this from public health perspective in terms of PSAs or campaigns of such? Or is that too granular, given the fact, obviously, we've kind of passed the phases of PSAs on smoking, et cetera?
Oh, can I speak?
Please.
Okay, this is Dr. Hughes. April is designated as Oral Cancer Month, and we usually provide some type of information. We do a press release, but there is not extensive, we haven't done an extensive campaign. And actually, that's something we would like to look at regarding oral cancer and smoking and the other effects that come along with that.
Thanks, Dr. Hughes. Other questions of Dr. Doring? Okay, with that, any other work groups looking to provide a report out and or informal feedback on some of the deliberations or their conversations with their peers?
We have for the adult population.
Please go ahead.
Okay, awesome. Lindsay, do you have the PowerPoint? Awesome, thank you. All right, so good morning, everyone. This is the Adult Subcommittee Population Report, consisting of myself, Dr. Verma, and Dr. Kimbers. So we took data from mostly the HPI and ADA and looked at different barriers of care. So to begin with, one of the big barriers that we've seen is that there's definitely a rise between different patient demographics. From 2005 to 2019, we can see its highest these disparities are in Hispanic and Black populations. So reducing costs will definitely be a big recommendation in reducing this barrier of care. Next slide. And then again, the other barrier of care, again, looking at costs again in different income levels. Clearly in low income levels, there's 32% of adult populations that won't actually obtain the care they need due to high costs. And then again, this chart just gives the comparison to not only adult populations, but also seniors and children populations from age group 65 and older and 2 to 18. Next slide. Again, this is another great chart. It shows what the estimated cost for a comprehensive adult dental care coverage in Medicaid programs. So if we look on the second line, that will actually be Maryland, and it shows that, oh, could you go back to that? Thank you. Just Maryland, that one of the key data points from this is the utilization rate, that if estimated, if this was a comprehensive Medicaid program, that would rise from 13% all the way up to 40%, which would be an extreme benefit to this barrier of care. Next slide. And then finally, this is just the map. This was actually the legislative report from MDH that shows just the dental care health professionals shortage within Maryland. So I think it'll be extremely important to target this areas for any kind of workforce programs that we may recommend. And finally, next slide. And so overall, these are kind of just the recommendations that we came up with: expanding access of Medicaid dental coverage to adult populations, increase Medicaid reimbursement rates for providers, expand oral health literacy and education, and finally increase funding to dental workforce programs such as the Loan Assistance Repayment Program for dental care providers. And then with that, I'll turn it over to if any of my colleagues, Dr. Verma or Dr. Kimbers would like to add anything. Thank you.
Thank you for putting that PowerPoint together. Really appreciate it. I think it's fairly straightforward as to some of the barriers that we're facing. So I appreciate us having the opportunity to have that discussion. Thank you.
Dr. Dow.
Thank you. So just as a refresher, I'm from the Maryland Higher Education Commission. So the map that you just showed of workforce shortages is of particular interest to our agency, because then we can target the colleges, universities that are offering even dental assistant training at the community college level and try to find ways to get new cohorts of students in and figure that out. I also noticed, Western Maryland, we have our regional higher ed center. And so maybe having a discussion with their dental school on how they can set up shop in Hagerstown to get some students up there to, put some roots down and think about setting up a practice there and addressing the workforce shortage that way. So I think there's opportunity for future discussion there around at least the student to workforce pipeline and thinking through that. So I just open up, I offer any opportunity to talk about that with you and thinking through how we coordinate and collaborate with the colleges and universities.
Thank you. Dr. Hughes.
When we look at the loan repayment program, I would suggest that we also look at including dental hygienists. That has been a question for some years. And, I've talked about it before, but I'll just reiterate, we are only able to fund 5 new applicants every year. And the amount that we reimburse has not changed since the program was implemented. And it's $25,000 per year. And we're looking at applicants with upwards to $700,000 in debt. So when we look at that in changing that program, that is something we need to look at. And another aspect that I would like for us to consider is looking at public health professionals, dental hygienists, assistants, and dentists. If you look at the state scale, they are reimbursed considerably lower than other practitioners. And these are people that would be placed in local health departments, and they're unable to hire. So they do have workforce shortages because they can't pay at a comparable rate. So of course, people are going to look at private practices, DSOs, whoever is paying competitively. So that's something else I'd like for us to look at, the rate at which we are paying public health professionals.
Appreciate, and as we entertain comments or our recommendations and so forth, I think obviously the one thing that should be considered, this may be a little bit non sequitur, is what kind of factor we have to put in there for rural areas. So if rates are standardized for a particular set of codes and so forth, some sort of modifier or scale for rural, just to add that extra incentive for providers and so forth. So something we can look at. Obviously, anything that we go to, I would like to have scored at some point in time, kind of pre-fiscal note, fiscal note, if you will, so we can have that for points of comparison, because everything's going to have a price tag as we'll see in session. So that's something I put out there, but we can discuss it at future deliberations. Other folks have comments or questions? Any other groups then for reporting out before we turn to our our speakers for the day today?
This is Christy from the
Yes,
Disability Subgroup. Oh,
okay.
Please go ahead.
it's okay. So we don't have a pretty PowerPoint, but I do have some information, statistics that I wanted to share. And I also want to thank the senior subcommittee and the adult subcommittee, because there is overlap, I think, in the information statistics, and even potentially the recommendations that the disability subgroup would make that are similar to what the other PowerPoint presentations suggested. The other thing that I would like to say is that I am not a dentist, so I speak from the advocate side of things, and I just want to put that out there. And of course, my notes just disappeared, so I'm going to log back in quickly. Oh. And I apologize. So one of the things that I wanted to highlight specific to disability and also oral health are that there is overlap in some of the health disparities and some of the things that occur, diseases that occur as a result of lack of oral health care. So people, adults with disabilities in Maryland are more likely to have obesity, to smoke, have diabetes, and have heart disease. And we know also that if people don't have access to oral health care, those diseases, there's overlap in those diseases. So I think that's something that we should consider just in terms of general health. I know that that's been a discussion that we've had, that oral health care directly ties to general health. And I apologize again, I'm trying to pull up the rest of my notes. Just a few statistics that I thought were worth sharing. From the CDC, 1 in 5 adults in Maryland have a disability, which is approximately 22% of our adult population. For our council, we use a national prevalence rate for people with developmental disabilities. My expertise is with people with developmental and intellectual disabilities. So 95,522 of the 6,045,680 Marylanders are people with developmental disabilities. 27.3 people aged 16 and older with disabilities are employed, compared to 70.7% of people aged 16 and older without disabilities. I thought that was an important statistic because that speaks to the type of insurance that people with disabilities have in comparison to people without disabilities. So people with disabilities, the majority of people with disabilities are likely to use Medicaid as their primary insurance. 17.6% of people with disabilities compared to 6.9% of people without disabilities in Maryland live below 100% of the poverty level. Again, that speaks to the type of insurance that people with disabilities may have. And then just another statistic, and this is an overall statistic, but I think it's something that's worth mentioning, is that 35% of the state's healthcare spending is on disability healthcare related costs. And that equates to about $21,118 per person of Maryland spending on healthcare costs for people with developmental disabilities. The other thing that I thought was worth mentioning, and again, I think some of these barriers to care are consistent across all of the subcommittees, but particularly for people who live in our rural parts of the state, access to transportation, lack of adequate health care, the cost of care, lack of caregivers, particularly those who are able to provide dental services to people with developmental disabilities in general, developmental disabilities specifically. And then another thing that came up quite a bit in my research is just this idea of caregiver training and information. So we know, just like with the senior group, that caregivers are the ones who are more likely to assist a person with a disability in getting and making appointments for the dentist. And so we need to make sure that not only are we training our providers, but we're also offering a platform for the caregivers to receive training and information about the importance of oral health care. And then one last thing that I think is important to mention, people with disabilities are part of our subgroup, and then we also have other disparities such as race, socioeconomic status, location, region in which a person lives. So when you add disability, there's this intersectionality of the barrier to care. And so I think that's something for our group to consider, that there are people with different socioeconomic statuses, people of different races. Disability is not more prevalent in one race or other disparity. So I think that we need to make sure that we also consider that there is that crossover between all of the different barriers to care. And that's what I have. Thank you.
Dr. Main, please.
Thank you for your presentation, Christy. That was really great. Just straightforward and very real. So oftentimes my practices in Frostburg, I will get people with disabilities who aren't able to sit through, say, preventive dental care. So I can get them an appointment with the oral surgeon to extract teeth, but for them to be sedated to have a dental cleaning or fillings, most regularly they would be seen at a pediatric dental practice. And just for the record, I want the whole group here to know that there is no pediatric dentist west of Hagerstown, right? So we would send patients to Hagerstown or to Morgantown, West Virginia, where one of the pediatric dentists does occasionally come to the hospitals here. But as far as going to get your preliminary appointment, you would be driving to Morgantown. So that to me is something we need to fix immediately. It's unacceptable to me that there's no pediatric dentist for the hour-and-a-half drive that it would take to go from Hagerstown to the western border. We need to fix that. Thank you, Christy, for your presentation.
Other questions? Other subgroups?
Yes, with the immigration subgroup, we have a presentation.
Please.
Immigrants, I'm sorry. Lindsay, do you have a PowerPoint?
We'll give Dr. Hughes control.
My apologies. My internet is unstable.
We can have the staff advance it for you, Dr. Hughes, if you want to proceed.
Can everyone see?
Okay, great.
Yeah, I have it up. Okay.
Yes. So can you go to the next slide, please? And I want to thank Dr. Carlson and Jennifer for our discussions. And is it advancing? Okay. So we wanted to start by making sure that we were all on the same page about the definition of immigrant and what we would be looking at in Maryland. So as defined by the Immigration and Nationality Act, a U.S. citizen is someone who was born
Dr. Hughes, do you want me to help out here?
I'm sorry. Can you hear me now?
Yes.
Okay. Someone, okay, I'm sorry, for born in the U.S. or to U.S. citizen parents or someone who becomes naturalized. So what we're looking at the definition of an immigrant as any alien in the United States, except one legally admitted under specific categories. And the most recent estimate is that there are approximately 12 million illegal residents in the United States. Next slide, please. So here's some terminology that we looked at. An alien, any person not a citizen or national of the United States. Or a permanent resident alien is any alien admitted to the U.S. as a lawful permanent resident. And so we're not looking at permanent resident aliens because they are eligible for insurance. But actually, most people, you know, some of the articles I've read, most aliens are have access to some type of insurance, but not necessarily able to afford that insurance. Next slide, please. Anyone residing in the United States who is not a citizen, but is legally recognized and is lawfully recorded resident, also is known as a permanent resident alien, a resident alien permit holder, or a green card holder. Next, please. And an immigrant may hold a green card, a visa, or no documentation. And that is number 3, that is mainly the population that we'll be looking at in Maryland. Next, please.
Okay, this is Dr. Carlson, Jean Carlson. I reside on the Eastern Shore and I'm on the committee with Dr. Hughes and Jennifer Szyminski. I was able to obtain some good information from the Chesapeake Multicultural Resource Center. We discovered that in Talbot and Caroline counties together, there is a total of approximately 5,000 undocumented immigrants. The executive director of this center told me that that's the number of people that they have registered in their database who have come to them and who have sought assistance. I was told that there are 2 to 3 new families that arrive every week from the border in Texas mainly, and some other states as well. That typical family would consist of a mother and 1 to 2 children. When these families arrive in Maryland, they have nothing. They come with nothing other than usually the clothes on their back. They come with no paperwork, no documentation of any type at all. Next slide, please. Initially, I thought that migrant camps were what we needed to look at. I was told that migrant camps would be the population that we needed to help address. Upon further research, I've discovered that migrant camps are actually made up of migrant workers, 90% of whom are American citizens. They're people who have chosen the life of moving around from place to place in the United States, usually in agricultural or seafood industries. The employers actually provide housing in camps for these people, and in most cases, healthcare options as well. When I inquired about what a camp would look like, I was told that it's very much like summer camp that we all went to as children, that there are dormitories and a kitchen building where people cook for themselves, eat together. The dormitories, there are bunk beds. There's of course indoor plumbing. So the conditions are not bad. The people do pay rent to the employers to live in these camps. But the employers usually take very good care of the people. They provide their health care. Sometimes they're self-insuring. Now, I said 90% of these folks are American citizens, so the other 10% are not. I asked, are the other 10% legal? And the answer is, well, they're supposed to be. They're supposed to be. No one wants to claim to be employing illegals. Next slide, please. The migrant camp locations in Queen Anne's County, there is one very large camp in the Sudlersville area, which is agriculturally based. In Dorchester County, there are 2 of these camps in the southern part of the county that are seafood industry based. And in Caroline County, there are at least 4 camps that are run by large farms. And of course, these are people who are picking fruit and vegetables. Next slide, please. Again, this data was provided to me by Matthew Peters, the executive director of the Chesapeake Multicultural Resource Center, which is a 501c nonprofit community-based organization right here in Easton, Maryland, where I am. He told me that he does not receive any government funding. It is a privately funded nonprofit. They help immigrants navigate the problems that they come to the United States with. They help them find housing, help them find healthcare, employment. But one of the main things they do is to help parents find some type of healthcare options for their children. As I said, most of the time, these people come with no documentation at all. And so what we need to explore is the way that these children are getting on Medicaid and Maryland Healthy Smiles. Next slide, please. Okay. Dr. Hughes?
So what we looked at, what some of the barriers to access to care. And some of the examples used have come from Mr. Peters. So number one is language. And in those counties that he serves, many of the immigrants speak Creole or Mayan, and it's difficult to find interpreters. But in my practice in Prince George's County, there were a number, the majority of the patients we saw were from Central America, and many spoke Spanish. And we would recommend that when patients came in, they would bring someone that could speak English and help to interpret. But what we found is even with dental terminology, for those that spoke English, it was still difficult. And in the department, it was also difficult to find interpreters, because the majority of the care throughout the health department, the interpreters were just spread too thin. Secondly, we thinking cultural differences. So this too is an example from what Mr. Peters noted, that many of the patients believe that if they waited long enough, the problem will go away. Well, we know what happens when those problems go untreated. Diamante driver. And so those are things we don't want an adult Diamante driver to happen. And we don't want that to happen in any children or any adult in our state. And also just many times, stressing the importance of keeping baby teeth. You know, parents would bring a child in with rampant caries, and they would think, well, just take the baby teeth out. But of course, we know the implications of that. Also, transportation. If clinics or offices are not on bus routes, a lot of times families don't have cars. And so that's the only way they can get to office. And then, of course, number 4, cost. As I spoke about earlier, there are low-cost insurance plans available for people who are not citizens. But even a low-cost insurance plan can, is not necessarily something that they can consider. Next slide, please. So another thing that Mr. Peters talked about was clinic availability times. Having routine hours from 8 to 5 doesn't necessarily work for all patients. And so the possibility of extending days, starting later, having evening hours is something that we should also talk about. And then number 6, racial inequality, the cultural biases that exist in care. And also fear. That could just be fear of treatment, fear of, are you safe coming to clinics? Will you be picked up by immigration? That also exists. And then one of the other barriers that was talked about is the wait time to get an appointment. Sometimes wait times can be extended out to 6 months. So what do you do if you have an emergency and you call a clinic and they say you can't come in? Then your next resource is to go to the emergency department. And that's a situation that we want to avoid. Next slide, please. So here are some of the resources that we are aware of in the state of Maryland for this population. Of course, we have local health departments, federally qualified health centers, specially funded programs. For example, there is a program at the University of Maryland School of Dentistry that specifically treats uninsured children. And Mr. Peters also talked about private funding programs, which he utilizes for his clients. He has relationships with private practices in his area in which they pay those practices to treat patients. We don't know the extent of that care, if it's only emergency or if it's comprehensive, but it does exist. And of course, our Mission of Mercy clinics, which treat adults. Next slide, please. So these are some of the numbers. At the Office of Oral Health, we have a program, the Oral Disease and Injury Prevention Program, which we fund health departments and other programs across the state for clinical treatment. And these are just some of the numbers. And of course, these numbers, we have to figure into COVID. These are not our typical numbers, but these are the number of uninsured children that these programs that we fund treated in fiscal year 2020. Next slide, please. And these are the numbers for our uninsured adults. Now, these numbers don't necessarily represent adults that are illegal, but because of course we know many adults are not insured, but this just gives you an idea of the number that we're seeing in these clinics that we also fund. Next slide, please. So here are some of our recommendations for access. To address ability to insure all residents, regardless of immigration status, to look at what the qualifications are to become insured, and to see if that's something that we can address. And to, secondly, to address our workforce shortages. As I talked about earlier, to address how we deal with long wait times, and develop programs which will enhance practice in rural areas, like pipeline programs. And, you know, to deal with the long wait times, is there to deal with I'm sorry, my phone is ringing. To look at the workforce shortages and how, you know, is it they need more providers, or what is causing these long wait times? And also to number 3, to look at medical dental collaborations, provide more oral health education in primary settings, and bring the care to the community, to, you know, look at putting more mobile units out in rural areas, and also to increase our use of teledentistry. Next slide, please. So that is our presentation. And are there any questions?
I just wanted to add, Dr. Hughes, before we open it up to questions, that in discussing the workforce shortage, it absolutely includes dentists. And Dr. Romaine, I just find it shocking that there's not a pediatric dentist west of Hagerstown, or, you know, not between Hagerstown and Morgantown. That's just, I was shocked when you said that. But you may also be shocked to know that here on the Eastern Shore, we have had 3 large general dental practices within the past 2 years that have permanently closed because we could not find any general dentists to come and take over these practices. So we have about 12,000 patients from between these 3 practices, but these people have nowhere to go, or they've tried, other practices are trying to absorb them. So yes, I just want everyone to know that the workforce shortage is real. It is serious. It is severe. I teach at Chesapeake College in the dental assisting program, and we are trying desperately to get another cohort of students going for 2022, but that doesn't address the shortage of dentists. We have a very, very difficult time attracting and obtaining dentists to come to the Eastern Shore, and it sounds like that's a problem in Western Maryland too. So when we talk about all of these various groups and the issues that they have to access to care, it seems to me that this workforce shortage issue is really at the top of the list. It has so much to do. For instance, Dr. Hughes was talking about the long wait time at the Federally Qualified Health Center here in our area. They have dentist shortages. They have dental assistant and hygienist shortages. Our FQHC here in this area is advertising for 7 dental assistants right now. So between the 3 practices that have closed down, everyone is looking for assistants, hygienists, and dentists. This is a huge reason as to why we're having difficulty treating everybody. So I just wanted to make kind of a passionate plea for the workforce shortage. It has everything to do with access to care for all of the groups that we're discussing. Thank you.
Dr. Amin.
I would echo and concur with everything that Dr. Carlson said. Yes, same here in Western Maryland. But specifically, I had a question for Dr. Hughes. I was thinking about immigrant children, and in particular, are they able to go to school, and do they have any access to care at school? Like I know here in Western Maryland, I'm excited to hear from my colleague, Dr. Seibert, about what's going on that way, but there's a lot of outreach at school. So do you have any ideas about that?
Yes, so we do fund, fund sealing programs around the state. So there is access there. But of course, during COVID, that has been limited. And, with this new variant, it looks like it will become even more limited. But, during normal times, there is that access in schools. Not all schools. We fund, I can't remember how many programs across the state, but they do exist.
And I just wanted to say also here that on the Eastern Shore of Maryland, our FQHC goes into the schools. Parents receive a letter at the beginning of the school year asking for permission for them to see the children. There are dental hygienists that go out into the schools from the FQHC here, and all children have have access to having their teeth cleaned and evaluated. Let's say that they're not providing a diagnosis, but if one of the hygienists from Chop Tank, it is actually community health. If they see something that needs attention, they will refer them to one of the Maryland Healthy Smiles dentists. So that hopefully that answers your question, Dr. Romain. Yes, children in schools, you're asking how do they get into school? And Dr. Hughes and I discussed that last night at great length, how these undocumented children do end up getting on Maryland Healthy Smiles and Medicaid when they come to this country with no birth certificate. They come with nothing. I'm not sure how places like the Multicultural Resource Center, I'm not sure how they navigate that and how they do end up getting these children enrolled, but they do. Dr. Hughes and I felt like the gentleman, Mr. Peters, would be a very good speaker for the task force.
Thank you. Delegate Bagnall, please.
Thank you very much, and thank you for all of your hard work. I just wanted to, as we're framing this conversation, be a little cognizant of the language which we're using to frame it. As you pointed out, this is a community that does have a lot of fear around immigration and immigration status, and the system is constantly changing. So I think we need to be a little cognizant that people are not illegal, that the laws are changing, that we do have undocumented residents in Maryland. And even that's a little bit of a misnomer, because everyone in Maryland is eligible for a driver's license. So you can acquire documentation, and every student is eligible for public school if they are resident of Maryland. So I just wanted to make sure that we were being cognizant of that, so that we're not inadvertently baking in a bias as we're trying to identify these barriers and remove barriers. And to that end, I was wondering if in your work you were able to identify how many bilingual practitioners we have, or if that information exists, or if that would be worth trying to identify how many bilingual practitioners we have, where they are, and what languages we have access to.
So that is not information that we are able to capture. I'm trying to think when practitioners apply for licensure. I don't think that's a question asked. So maybe someone else would know that. Otherwise, I don't think we have a mechanism to capture that data.
And maybe there's a recommendation looking down the line.
Before I go to Dr. Doring, I will make note that the general parlance from the federal government going down through CMS and HHS, especially as related to government-sponsored healthcare, is undocumented. So we will try to use that as our parlance. Dr. Doring, please.
Just wanted to remark about the bilingual. I have a dentist in my office that speaks English and Spanish, and also quite a diverse team here that speak multi-languages. And I did read a report from our dental school that this is the most diverse class that they've just admitted that they've ever had. So I certainly think with diversity comes multicultural and diversity in languages as well.
And I'm sure Dean Reynolds would love to tout that, but unfortunately he's had to step away from the task force meeting. So I will tout it for him. Dr. Verma, please.
Thank you. I just wanted to remark on the question that was asked whether the practitioners are required to provide that information for licensure. They are not. That is not a question that is requested at the time that an initial license is applied for, nor is it a question that is asked for re-licensure. So just to make you aware, the only thing I can say is, as a private provider myself, I have noted that that's a question that's sometimes asked by insurance companies on their certification as to whether or not that's a provider that has that in order to provide some more information.
Yeah, and as we go through this, there's kind of spiders out to a number of different issues. For example, the anti-discrimination regulation that the Biden administration will repromulgate, that it stems back from the Affordable Care Act, has protects against discrimination in federal programs against those with limited English proficiency. So that will cascade to the service of certain populations. So we'll obviously morph and pivot as we have more bright guidelines that can help inform our recommendations. Ms. Russell, please.
In line with communication and language accessibility, I think it's also important for this task force to consider using plain language for people with disabilities. So a lot of times practitioners tend to use the jargon that they're familiar with, and for people with disabilities, that's hard to understand and increases anxiety in receiving services. The other thing that I would be interested to know is if there are dentists who are also fluent in American Sign Language, and is there any training for people who use alternative communication methods, like technology. So just things to think about too, if we're talking about communication and pointing it back to the disability subcommittee and what would be considered for us.
I mean, as you say that, I think to myself that any kind of recommendation that we have obviously could just kind of sweep it generally in. Any and all recommendations should take into focus, and I'm winging it here, federal requirements of the Americans with Disabilities Act, and there's a number of different acts which protect protected categories and classes and look out for discrimination that we could most certainly allude to. Sometimes they're not properly enforced, but we can certainly look in that regard. So any other questions before we move on? Because I do want to take time for our speakers who have been generous enough to give their time today, have a rich amount of information to share with us, and I do appreciate the dialogue, but I also want to give them time for questions since they've been selected for the information they're willing to share. So before I pivot over there, does anyone have any remaining questions?
Alex, this is Mary
Yes.
Backley at MDAC, and I'm on the Medicaid population group. And I understand in the spirit of time and for the speakers, but I did report last time that the group was developing a grid on Medicaid populations with infants, children's, adults, dual adults, and addressing each of the barriers. What I find interesting with the presentations this morning is there's a lot of overlap. There's a lot of repetition within these population groups. So it was really quite extraordinary listening to everybody because we did complete the grid. I shared it with Lindsay late a few minutes ago. I don't think she got it, but it is completed. And many of the recommendations that all these groups are making is really what is included in our grid. And it's comprehensive. We did not want to leave any recommendations out. I am more than happy to turn this over to any of my subgroup members for further comment, but I find it encouraging that there are a lot of replication and repetition in the recommendations, which means that in my mind, it's going to be a very impactful in terms of solutions that the task force does come up with. Brooks or Dean or Jennifer, if you have any other further comment.
That was my same observation, Mary, that there's a lot of overlap, a lot of the same challenges, that even if you have coverage for the whole entire Medicaid eligible population, if you don't have the providers in the locations where they're needed, then you don't have access. And then if you can't provide the access to the providers through transportation that is needed for some populations, then you also have an issue. So and it goes across the spectrum. So it's obvious, I think when we were chatting, Western Maryland and Eastern Shore have their challenges geographically, and that impacts all the populations and subgroups that we're talking about. But also too, there's also, how do you get providers where providers are needed? And even some areas where we kind of think twice, really, why would there be a shortage there? Even in some urban and suburban areas. So I think you're spot on in your observations, and that this goes across the whole spectrum of subgroups we're discussing.
Thanks, Dean. So what I'll do is I'll have staff make sure that we circulate that product around to the task force members so that we can take it into consideration next time, since obviously that will probably dedicate a significant portion of our deliberations to go into that. And since it's all kind of tying it together. But with that, I'd like to turn to our speakers so we can again have time to provide some inquiries to them. And we'll start off with Dr. Eric Tranby, who's with the CareQuest Institute for Oral Health, who'd like to make a presentation, and especially interested in the research that you all may have seen with regard to, I think it was the Journal of the American Dental Association, talking about oral care across lifetime. And obviously, as all of you know, with clinicians, there's different needs at different points of your life, and different costs and access issues associated therein. So with that, I will turn it over to Dr. Tranby, and it is yours, sir.
Thanks, and thank you for having me today. It's been a pleasure to work closely with those of you in Maryland. I have a lot of familiar names on this call with Mary and Dean, and Dr. Romaine. So really a pleasure to present to this group. Next slide, please. For those of you who aren't aware, CareQuest Institute for Oral Health is the ownership group for DentaQuest, as well as a series of dental practices across a number of states. We have a wide-ranging portfolio that includes research and grant making, health, specific health improvement programs, education, policy, and advocacy work, in addition to some for-profit, as I said, with DentaQuest and innovation arms. So just wanted to give an overview. If you weren't familiar with CareQuest Institute, would encourage you to visit our website, and you'll see, as I go through the presentation, I have QR codes and links to everything that I'm discussing today. So happy to have all of you see have you see all of our research. Next slide, please. And then next slide. As I said, everything I'm going to be presenting today is on our website. There's a QR code with a link to our website, and I will, as we walk through, you'll see QR codes if you're interested in what I'm having to say. Feel free to scan those in and have fun. We published about over 100 articles just in the last year, several hundred in the last couple of years that will hopefully you can find impactful. Next slide, please. So first, I want to talk a little bit about the state of oral health equity. Before I get into the lifespan analysis. So the state of oral health equity in America is a large-scale national survey that CareQuest did with the National Opinion Research Center in Chicago, of 5,400 adults. And we asked detailed questions about oral health history, perceptions of oral health, and really have used that survey to understand what is going on across the United States today, and how and the struggles that are inherent in the oral health care system, many of which I have heard as I've sat on this call and had the privilege of joining today. Next slide, please. So important thing to consider is that everybody understands that their oral health is important. 95% of all respondents believe there's a connection between the health of their body and the health of their mouth and the health of their body. 7 out of 10 respondents say that oral health is as important as their physical health, and nearly 25% said it's more important. People who've historically had the most difficult time accessing the oral health system, especially people of color and those at low income groups, are particularly likely to believe that their oral health is as or more important than their physical health. Next slide, please. These inequalities are pervasive. 13% of all adults are embarrassed about the state of their teeth, mouth, or dentures. 21% of Black adults and 18% of Hispanic adults report being embarrassed, significantly higher than the population as a whole. And Americans making less than $30,000 a year are significantly much more likely than Americans making more than $100,000 a year to say that the state of their mouth limits their ability to have a full, successful, enjoyable life. Next slide, please. Inherent in this is that symptoms of oral disease are common. 56% of the population reports that they have had one or more oral health symptoms in the last year, with the most common being things like toothache, cracked or broken teeth, swollen or bleeding gums, indications of periodontal disease as it go in there. As happens. However, a lot of these go untreated. 56% of the 56% who reported having an oral health symptom did not go to see a dentist, often because they can't afford it or have difficulty accessing dental care. 65% of respondents who lost their health insurance due to a job loss or change due to COVID-19 had one or more of these oral health symptoms and did not get any treatment for it. So those of you who are in clinical care, I think know that this is true. There's huge unmet needs in the population as a whole, and we need to do more to meet those needs. Next slide, please. I wanted to give a little bit about the insurance landscape in the United States for adults. On the left is medical insurance. On the right here is dental insurance. In a pie chart, you can see, and the numbers here are millions of adults being covered. You can see here that by far the biggest difference between the left and the right is the number of those with no dental coverage or reporting no dental insurance. Americans are 3 times more likely to lack dental insurance than they are to lack medical insurance. So one of the biggest gaps that we see is in coverage. Next slide, please. Just to reinforce this, an estimated 75.6 million adults lack dental insurance, 3 times more likely, as I just said. Lower income adults are significantly less likely to have that insurance than higher income adults. Next slide. This has grown through the course of the pandemic. 6 million of those 76 million adults reported losing their insurance in 2020 or the first part of 2021. Asian adults are significantly more likely, 3 times more likely to have lost their dental insurance, and Black adults were 2 times more likely to have lost their dental insurance due to a job loss or job change associated with COVID-19. What often happens is that those folks either remain uninsured until they find an additional job, or they may go on Medicaid or some other form of government insurance. Next slide. This matters because we know that the oral health spending and quality of oral health over the lifetime varies profoundly depending on which type of insurance you have. So here I'm speaking a little bit to our the article that was published recently in JADA. Next slide, please. So why we talk about oral health over the lifespan is we're using some theory framework comes out of often the social sciences, comes out of developmental sciences, is being increasingly more applied into healthcare. That's the idea of life course theory. So life course theory really talks about developmental processes and developmental stages, how something that occurs at a point in time early in life may have long-lasting implications throughout the course of life, and that one's health trajectory is determined by a huge variety of characteristics, but that those trajectories are associated with internal forces, external forces, ecosystems, insurance types, a whole host of different things that go into here. And that they're across a person's life course, there are kind of key turning points. There are times in which you can make the greatest impact. The paper you'll see is largely descriptive based, but it covers, it includes all the dental claims and medical claims from about 70 million people in the United States. So a hugely robust analysis, really truly a big data analysis that gives us a fundamental mapping of spending over the lifetime. Next slide, please. So as I said, key elements of life course theory: health trajectories, changes over time, when you can see those turning points. By making a change at a key point in time, you can set somebody on a different path. The environment matters, what goes on in the community, what goes on the network, and with profound equity in considerations, including social determinants of health and insurance coverage. Next slide. Data sources, I just talked through the IBM Watson, Medicaid, and commercial claims data sources. These cover, as I said, combined 70 or so million lives in the United States. We have all the medical, all the dental claims that occur. We understand the limits of claims. We can't see folks who either don't have insurance or don't access dental care, but are still very robust data sets. We looked at things like cost and utilization of diagnostics and preventive care, restorative care, oral surgeries, anesthesia, periodontics, and as well, something that doesn't often happen in these type of analyses is we looked at the cost of medical care for dental conditions. So dental care done by a primary care provider, that might be a fluoride varnish, might be an oral health assessment, ambulatory surgeries that happen in a surgical center for oral health conditions, emergency department visits, inpatient admissions, oral cancer. And so really have combined a huge variety of oral health conditions into a single analysis for, I think, is one of the first times that this has been done out there. Next slide, please. What we see when we look at this is very different patterns of spending over the lifetime, dependent on which insurance that you have. So you see the circles here. Didn't want to get into the fancy kind of fancy visualizations here, but some peak things that you can look at as you're just kind of trying to visualize. So in the paper, you will see that we break everything down into very small categories. I'm focusing on big categories here to make this useful. But we see among Medicaid enrolled children and adults, we see big spikes. So it's in that 6 to 9 kind of range associated with predominantly early childhood caries. You'll see that major dental procedures occur there. And then another spike, kind of that 15 to 20, often associated with major restorations or third molar extractions. We also see that there's this valley or trough of oral health spending that occurs in that age 21 or 22, 23 kind of period. Why this is particularly meaningful, as we'll see later on in the presentation and some of the reporting that we've done in Maryland, the age groups most likely to visit the emergency department for dental, non-traumatic dental conditions are exactly this age group. Right, so they are the least likely to access oral health care and are the most likely then to need to go to the emergency department due to non-traumatic dental conditions. And then the last piece I'd like to point out here, and as we see in Medicaid, oral health spending among Medicaid enrolled adults is very low. This is most likely associated with coverage. We know that many states, including Maryland, have limited coverage for adults in Medicaid. And so much of the burden for covering oral health care in Medicaid rests on the medical system. And so the majority of the costs among those, say, 40 and over in nationwide in Medicaid for the treatment of dental conditions occur on the medical side. Now, these include things like, as I said, ambulatory surgeries, inpatient admissions, treatment for oral cancer, that factor into here. Next slide, please. Here we see a similar graph, but focused on those that are both commercially insured or have supplemental Medicaid at post 65. So the supplemental Medicaid plans are employer provided supplemental Medicaid, or Medicare, excuse me, employer provided supplemental Medicare plans. First thing to notice over here is that there are higher costs, which means more coverage for care. And so if you kind of compare the x-axis on the last slide and this one, you'll see that the y-axis, you will see that the total cost, average annual cost is $300 or $400 in Medicaid, up to $700 for on the commercial side. You'll see patterns are very different. Those children commercially insured, we don't see that big spike for early childhood caries, but we do see a large spike predominantly associated with third molar extractions. And we see that the pattern of spending is different. Spending goes up over as people age, goes down a little bit as folks generally lose, are less likely to have teeth or have more teeth extracted, and then so significantly lower costs on the medical system. So more costs, more utilization borne on the dental system, fewer costs on the medical side than that are associated that are in there. So kind of peak costs is at much different time depending on the coverage that's available to folks. Next slide, please. Next slide, please. And so you may say, hey, are these costs, they may be just associated with differences in utilization. Yes, that's true. Medicaid enrolled folks are significantly less likely to utilize the dental system. This is often associated with coverage. That goes into this as well. On the far right, you may see, well, we know that reimbursement rates are different between Medicaid and commercial. That's also true. But when we adjust cost using a common fee schedule, and so making sure that we're strictly comparing apples to apples. All the previous analysis was what was paid to the provider. This is adjusting everything based on exactly the same fee schedule. We still see that there are significantly higher costs on the commercial side. And then finally, there are profound implications for the way that this works. The middle graph shows, I know it's a little hard to read, but shows inpatient admissions for non-traumatic dental conditions in Medicaid and commercial, and then oral cancer in Medicaid and commercial. We see that nearly over the entire life course, people in Medicaid are much more likely to be admitted to the hospital with a non-traumatic dental condition. It's an abscess. Most common are abscess or some infection caused by untreated dental disease. And then oral cancers had significantly higher rates earlier in time among those enrolled in Medicaid than those enrolled in commercial insurance plans. And though that's a combination of course, of lifestyle factors, of coverage, of lack of access to care. We know the importance of dentists in early identification of oral cancer. And we're doing some research right now, in fact, with Mary Backley to demonstrate some of that. That early identification of oral cancer, that dentists play a massive role in that. So not being able to routinely access dental care has profound implications for folks at risk of these cancers. Next slide, please. So the life course view, as you can see, again, it's simplistic, it's descriptive, but I think very, and we have plans and research in the works where we're actually tracking people over the course of their lives. We have up to 20 years of data in some of our data sets to say, hey, you do this at age 6, here's what goes on at 16 and 26 and 36. But I think that we have some important findings here to really say that being oral healthy is a lifelong process. So it's not just, it occurs over the course of somebody's life. Life course theory really has kind of bidirectional implications, meaning that we both have to understand how the system is built to understand the outcomes of the system. But we also have to understand patient level factors and environment and community level factors to understand somebody's full course of life. And then finally, we've seen that there are 2 separate yet disparate systems of coverage that shape access to dental care and may kind of thwart efforts to improve oral health if there is not kind of fundamental changes to the way in which those systems may work. Next slide, please. Importantly, patients themselves want access to similar systems. There's strong agreement nationwide that comprehensive oral health coverage for adults should be in Medicaid and Medicare. Nearly 2/3 of American adults strongly agree that Medicaid and Medicare should have comprehensive dental benefits. If we combine strongly agree with agree, that number goes to 90 to 95%. And that is across the political divide. We see very similar patterns on both liberals and conservatives and Democrats and Republicans. People of color, especially Black and Hispanic respondents, are more likely to say that coverage should be in Medicaid and Medicare. As we've seen earlier, this is maybe part of the profound lack of access that some of these groups face. They are aware of it and they want more access to care. Particular to Maryland, next slide, please. Maryland adults are more likely than the national average to say that their state should include comprehensive dental benefits. 84% of adults strongly agree that that should be the case in their state, more likely than nationwide population as a whole. Next slide, please. What can happen if folks don't have access to routine care is emergency department visits, something that we've known. And we've done comprehensive work in Maryland. 4% in our nationwide survey, 4% of respondents visited the emergency department in the last year for pain or discomfort. Black respondents were 3 times more likely than white respondents to go to the emergency department. Those making 8% of those making $30,000 a year went to the emergency department in the last year, compared to 2% of those making $60,000 or more. Next slide, please. We've done some work in Maryland. As you may be aware, we released a large-scale report in 2017. We recently, using data from HSCRC to look at costs associated with emergency department visits in Maryland. We have updated that last year with a report released in August, I believe. Next slide, please. So wanted to preview that report if you hadn't seen it. Again, HSCRC data were focused on non-traumatic dental conditions and focused particularly on adults, given we know what Medicaid coverage looks like for adults in Maryland. Next slide. So we do see that trends are going down in Maryland. There is some good news story here. Number of visits has gone down from 52,000 in 2013 down to 35,000 ED visits for non-traumatic dental conditions. Similarly, the rate in the population has gone down from 118 in 2013 to 77 in fiscal year 2019. Next slide, please. Nevertheless, Maryland continues to have significantly higher rates than the national average as a whole. While the gap has shrunk from Maryland having nearly triple the rates, it continues to be a significant gap. 280 in Maryland, 283 adults out of every 10,000 have visited the emergency department, compared to 172 in the population as a whole. Next slide, please. There's also a disproportionate share that's borne by Medicaid in Maryland. So the slides, want to spend a little bit of time on this slide, but let's focus on fiscal year 2019. Of adults in Maryland, 16% are enrolled in Medicaid. So you'd expect that if ED visits are distributed equally, roughly 16% of all ED visits would be borne by Medicaid enrolled adults. What we see is that ED visits for any reason are significantly more likely among those among adults. So 33% of all ED visits in Maryland for any reason at all are among those enrolled in Medicaid. Okay, so if we know that it's a third, even though that seems higher than it should be, then we'd expect that roughly a third of all visits for non-traumatic dental conditions would be paid for by Medicaid. Again, it's higher than you'd expect. 54% of all visits for non-traumatic dental conditions are paid for by Medicaid in Maryland, to the tune of tens of $millions a year. About $12 million a year is covered by Medicaid for emergency department visits for non-traumatic dental conditions. All those costs are detailed in the report if you're interested in looking at those. Next slide, please. So what we see is that Medicaid enrolled adults in Maryland have a disproportionate share of ED visits, significantly higher than the national average. We focused on the fact that those are focused on kind of that young adult, those newly enrolled or eligible Medicaid folks. And we know that there's strong support for comprehensive Medicaid dental benefits in Maryland and nationally. Next slide. So with that, happy to answer any questions. And then next slide, just so you can see my contact information. My contact information is there. Please feel free to reach out with any other questions as well. I know I went quickly. I was trying to give time for all the speakers.
I appreciate that, Dr. Tranby. It's really fantastic information. And again, the task force will have the benefit of the collateral as well as to listen to this all over again at your leisure. So I will put this over to questions for Dr. Tranby, and I would ask that if you suspect that a deeper dive into the material might be more, might answer your question, defer on it so that we can make time for our speakers, but I don't want to close out a line of questioning completely. So let's run the table. Well,
I've stunned you into silence. No, again, you have everything that's there. Everything that we produce is publicly available, ready for use by you and others as you're focusing on Maryland and the work that's done there. Please reach out any way I can help. Any questions that you may have, I'm more than happy to answer.
Thank you so much, Dr. Tranby. I appreciate it. Next, we will move on to Dr. Norman Tinoff of the University of Maryland School of Dentistry, distinguished pediatric dentist, who will provide some information from us, and we will then entertain questions after his presentation. So, sir, it's off to you.
Thank you to the Maryland Oral Health Task Force. I only had 3 slides, so I'll be brief. The question Dean Reynolds asked me to address was, does dental fees increase access to care? So we have a natural experiment that's been occurring in Maryland because of what you all remember is the death of Diamante Driver in February 25th, 2007. At that time, Secretary of Health John Comer appointed a dental action committee to make recommendations to improve access to oral health care. One of the 7 recommendations was to increase dental reimbursement rates to 50th percentile of the American Dental Association's South Atlantic region. So this was in 2008, and when we had a recession going on, but the legislature passed Senate Bill 91 to increase all dental fees in Medicaid to the 50th percentile of the American Dental Association's South Atlantic region. But because of the recession, things got slowed down in 2008. Only preventive and extraction codes were increased. And then finally in 2013, restorative codes were increased, but not all the fees were increased. So let's have the next slide. So here's part of the natural experiment that we have. So you can see on the right-hand column, the most important column is dentists billing over $10,000 per year in Medicaid. So these are the ones that really are engaged in Medicaid practice. In 2009, there were 479 of the 4,082 dentists that were Medicaid providers that were billing over $10,000 per year. 2016, that increased to 1,092. And this is due, I think, primarily due to that increase in fees. And so we see that 2.3 times the number of dentists are participating associated with the increase of fees. So I think this is a good natural experiment to show that increasing Medicaid fees increases access to care. Let's look at the last slide. This adds a little bit more complication to the whole story. And this is data from 1997 to 2017, over a 20-year period. So let's concentrate on 2007, before the fees were increased. And you can see over on the right-hand column that Medicaid was paying out about $87 per child per year. If you look down to the bottom, 2017, you can see that Medicaid was paying out about $258 per child per year. And that, we think, is a pretty reasonable fee when we look at the amount that for our average patient at the university that's on Medicaid. That's about what we're seeing. So you can see the fee increases did increase the amount per child. But more importantly, if we look at the right-hand column, actually the Medicaid population column, you can see that in 2007, there's about 500,000 children on Medicaid. That's the figure in brackets shows the total population, not just the HEDIS population. In 2017, that increased to 750,000 population. So both the fee increases, but more importantly, the number of children in Medicaid increased the amount that Maryland was spending, Maryland and the federal government, from $43 million in 2017 to $187 million in 2017. So I just open this up for discussion with regard to our natural experiment that we've had in Maryland, showing that Medicaid fees are important for access to care. Any thoughts or questions?
If that's the conclusion of your presentation, Dr. Tinoff, I will open it up for the main questions. I'm sure that we will have data and further conversations about the where rates stand and what the best benchmark could or should be. There's lots of them out there, and obviously they have to be reflective of, I would suspect, geographic disparity, as well as things like CPI medical, so on and so forth, since they can't obviously stay static. And there are mechanisms by which other rate schedules are updated, even if they are pegged to a certain benchmark. But that's all items that we can explore. Any questions? Thank you for your time. We will now move off to Dr. Gretchen Siebert, dentist from Allegheny County, who will provide some insights to the experiences out there, especially in the local jurisdictions and so forth. So with that, I'll turn it over and thank you.
Hello, everyone. First of all, I want to thank the group for your kind consideration in letting me go last today to minimize lost clinic time. As Dr. Doring and Dr. Romain said at the beginning, clinic time is precious, and ever more so now because of the additional things we have to fit into a clinic appointment due to COVID. I also want to quickly answer Dr. Romain's earlier question before I go into my presentation, because my presentation doesn't answer it. She had asked about the sealant program activities in Allegheny County. We are fully operational. When the schools have been open, we have been in the schools. When the schools have been closed, we have been going to schools at like lunch pickups. We've had tents and tables. So our sealant team never stopped, and we are trying to continue to meet the kids at the schools where they are, so much so that we've actually expanded our program during COVID because we see such a lack of access to care for kiddos. We used to only see first, second, and third graders. We now see any child in any school. So we're seeing pre-K students and some early Head Start students all the way up to 5th grade. Any student in the school that we can get consent from a parent, we're seeing those. And we work closely with the nurses as well to make sure if we're having trouble getting consent that we circle back and make sure we see students that need to be getting an oral evaluation when we're in the schools. And talking about provider pipelines, Dr. Romain was my host when I was a dental student and I did my externship in rural dental care when I was in dental school. So she is definitely one of the key reasons that I decided to set up practice and eventually became the dental director at the health department in Cumberland, Maryland. So I have to recognize her for that part of my journey and being that inspiration. So my presentation, I'm just doing a quick snapshot about dental care access for individuals in our county. There was already a problem that was beginning to exist before COVID, and COVID just accelerated a problem that we were already seeing. So I have some statistics to explain that. And if you can go ahead and go to the next slide. When we look at statistics, the way we report as a health department is our fiscal year runs from July to June. So it's not a calendar year. Sometimes that causes confusion. But if we look at FY19, which would have been our last full fiscal year prior to the pandemic, our health department treated 2,139 unique individuals. So we measure that as first visits. So those are unduplicated people. In FY20, which would have contained like the first 3 months of the pandemic, right at the end, it would have been March through June of 20. We can see that our patient visits were already a lot more than they were in FY19. And that's with being shut down, except for emergency visits at the end of FY20. And then we see a little dip in FY21, which would be expected because of what was happening in the landscape because of the COVID pandemic. So now for FY22, we only have stats through the end of October. We've had a computer issue, ongoing glitch, where we can't get to our November stats. So far, just in the first 4 months of FY22, we've seen almost as many individual patients as we saw in the entire 12 months of FY19. If we continue at the rate that we're at, just multiplying by 3, we would be at 6,378 individual patients that we treat this year. And then if you look at the trends below that for emergency appointments, so these would be patients that come to us by referral from our emergency department, which is co-located literally across the street. So people who go to the ED with an urgent dental need, we try to see those people same day or within 24 hours. These are the stats for those folks. Then you can see even with the pandemic, that is continuing to just go up. We didn't even really see a downshift. Next slide, please. And this is just the same stats there in column form, just to make it a little more visually accessible. So there's the first visits that I just talked about. And next slide. And then this just shows our trend for emergency patients. So these are patients where they're really on the precipice of a life-threatening situation, and they really need emergency dental care. If you can go ahead and go to the next slide. To further illustrate the type of care that's being provided, I wanted to show the number of extractions. So the patients that we're seeing for emergency care, and really the vast majority of our adult population and many of our child population, these are people that they're at the point where the only care that would be useful to them is to actually remove the tooth. So their tooth or teeth are at such a point where there's not anything left that we can do to fix it. And really maintaining the tooth in their mouth is actually life-threatening when you think about sepsis and things that can occur when we think back to Diamante Driver. So in throwing these slides together quickly last night, I neglected here at FY22, we're at exactly 1,500 extractions as of the end of October. So projecting FY22, if we stay at the same rate, we're going to be at 4,500 extractions. So you can see a trend there. Next slide. That is just here on the bar graph. You can see the amount of people that are coming to us with hopeless teeth, where really the only thing we can do for them is extract the tooth to get them on the road to better health. Next slide, please. And then the last set of numbers, statistics that I have from our program, this is just our total patient volume. So this is all visits, not just first visits. So this is the amount of care visits we're providing in the clinic. And again, I made the same error last night getting these slides together. For FY22, through the end of October, we have provided 3,103 individual patient appointments or individual patient visits. So we're projected to get to about 9,309 if we stay at that same rate. So next slide. If you look at the bar graph, you can see kind of that pandemic dip that we saw in some of the other stats, because this also includes well visits, which we were not able to do during much of the beginning months of the pandemic. But you can really see what I have my attention on, which is our total patients seeking care across the board, the trends that we are seeing in our health department here in Allegheny County. So next slide, please. We work closely with our care coordination unit, which is also a part of our local health department. And they routinely survey dentists to find out about provider availability. And this was already declining prior to the pandemic, but like I said, the pandemic just, I think, put a lot of providers in a situation where they were already struggling to provide dental care when you do a cost benefit analysis. And when you layer in all the extra time and costs of COVID, for a lot of providers, they've really had to make the tough decision to reduce the amount of medical assistance and uninsured that they're seeing, if not eliminate. So next slide. When we do a survey of local providers, we find that there are 34 dental practices in our county. Of those 34, 25 have active MA patients. When you further break that down, 4 of those 25 provide very specific procedures to very specific populations. So like orthodontics, which are braces. So those would not be typical practices that somebody who's really in an acute emergency situation could find access at. We find that of those 25, 11 are telling us they're not accepting any new patients that are uninsured or have medical assistance because they're so backlogged with their existing patients. And then we also found that 7 additional practices have limited their patients to people they've seen within a year, which in light of the COVID pandemic and patterns that we see, especially with parents taking children to the dentist and feeling safe about that, a lot of children haven't been seen within the past year. So that effectively eliminates a lot of people. So when you subtract out all of those, what that means on the ground here is that we have 2 practices that are really actually actively taking new MA patients. So when I say solo dentist, I mean private practice. So Dr. Romaine is an example there. So besides those two practices, there is the health department, and that explains the trends that we were seeing in those columns and those numbers there. And just for reference, in our county, about 50, well, it's always a little over 50%. It's currently about 56% of children in Allegheny County qualify for Medicaid. So greater than 1 out of every 2 children financially qualifies for Medicaid. That just gives you an idea of the financial situation of most of the families in our county. And that is just a quick snapshot of on the ground what's happening in Allegheny County. And I echo what a lot of other people have said about provider shortages. You can see that the demand is increasing. We've got 5 rooms and we've got the providers that we've got. We just don't have any more space to see more people. We're bursting at the seams. So the access is really limited by providers that are available. And I heard other presenters earlier talking about dentists being available, the Eastern Shore, Western Maryland, hygienists, dental assistants, across the board. We have a hard time recruiting, especially full-time staff. Thank you so much for your time and attention.
Thank you, Dr. Seibert. We'll drop off. Okay, fantastic. We are getting ready to run on at time, but I do want to keep time open for questions. And if people have to leave at noon, I understand. But do we have any questions from the task force? I do have one, but I want to make sure that I get to other folks. Dr. Doring.
Thank you, Dr. Seibert, for your presentation. In Western Maryland, do we have a sense of how many Maryland residents maybe cross state borders, say West Virginia or to Pennsylvania to get dental care?
So hold on a second. Dr. Seibert, let's get you off mute.
I'm sorry. Thank
You're
you.
good.
So we have, we actually are experiencing the reverse. So we're sandwiched between Pennsylvania and West Virginia. We actually have many patients being referred to us from a federally qualified health center that's not too far from here in Hindman, Pennsylvania, because they're so limited on their providers and their services. Those patients, if they come to our health department, have to pay 100% of the Maryland full fee, which is actually higher than most of the private practice fees in our area because they're not Maryland residents. We also have Maryland residents traveling from other areas in the state to Allegheny County, depending on the plan they have and the age. It's primarily adults. We have a lot of adults with a medical assistance. Their MCO calls around in increasing radii to find a provider that will see them. And we've had several people from very far east of here end up in our health department clinic because they can't be seen timely with an urgent need. And we also, of course, have many West Virginia residents that call us because there's not a safety net dental catch-all system like there is in Maryland and West Virginia. There just aren't services available for West Virginia residents. I hope that answers your question, Dr. Doring.
Dr. Seibert, question for you. So as you were talking about the slide up, and we don't have to pull it up for the providers, is it a matter of space by which to take care of folks as well as providers, or both?
It's all of the above. Reimbursement rates are lower. So when you already have your chairs totally full and your schedule is totally full and you're trying to pay overhead and staff, and you're balancing taking a medical assistant patient who may not have transportation and may not even be able to make it to the office versus a patient that probably has reliable transportation, good insurance, or is paying cash. That's a tough decision to make, but private practitioners need to stay in business. So they are forced into a tough decision. And we now have to wear much more PPE. We've all installed lots of different vacuums and things that cost a lot of money to upkeep because of the pandemic. And so the cost of providing dental care has really skyrocketed because of all of the additional things that we have to do to keep our patients and our staff safe to mitigate COVID.
So are the chairs at the local health department, where's the actual situs of care where the actual care is delivered? Is it on at the local health department in a building?
It's in the building I'm sitting in right now.
Okay.
So we used to have 4 chairs, and in January we turned a storage closet into a 5th chair. Just hoping to get ahead, but that it's full. I mean, we are in a situation where we have a book of short call people that we call that need to be seen right now. So whenever we have a cancellation, we fill that with a patient, typically within 10 to 15 minutes. There is rarely a day that we have holes in the schedule.
So one thing I'd posit to the task force is in terms of physical footprint, right? So in these rural areas, it's a physical footprint of more space in which to accommodate additional chairs. And then in terms of getting certain specialists that might not exist out in certain rural areas out there, whether that be grant programs or for those of you who are familiar, federal circuit courts are called circuit courts because back in the day, they used to ride a horse around to take on cases. I'm not suggesting we should put dentists on horseback, but there's certainly the possibility of getting dentists to do a circuit out, depending upon the incentive and payment programs, to make rounds, since they're all licensed in Maryland, out to other areas. So that's conceptually something that came to mind, but we can have for broader conversation. Since it's obviously a matter of space, rates, folks, a combination. Questions from the remainder of the task force before we get ready to close out? Okay, well, we've had a lot of great information over the last several months, lots of presentations. Our library is full, chock-a-block of data and presentations and lines of thought in areas that we should explore. So we've stocked the fridge. It's time to start cooking. And we will take the time about that here over the next several months as we do our internal reports. I have no other closing comments or remarks, but I will invite Delegate Bagnall if she has any closing remarks for the task force before we disband.
Just thank you once again. Have a wonderful holiday. I look forward to our meeting in January. And I agree. We're going to start putting this data together and come up with some good recommendations that I can champion.
Thank you, Delegate. And I echo the delegates' best wishes for the holidays for all of you all. And we will be in touch with regard to our meeting time for January. So have a great new year, and we'll look forward to seeing you again in 2022.